So we would like to welcome you to our event tonight. Again, we would like to welcome you to our event tonight. My name is Linda Wyatt Simpson. I am the chair of the Physical and Mental Health Committee of the Trenton Alumni chapter, here in Trenton. I hope that you are ready for the conversation. Tonight we are talking about menopause, the impact on women, and I hope you got your fans ready. So, with no further ado, I would like to introduce our moderator for tonight, Tracy Daniels.
Thank you, Linda, and good evening, everyone who has took the opportunity to join us tonight for our presentation on menopause and other topics that impact all of us on a day-to-day basis, not only individually, but also our family and friends. So we have a wonderful presenter for this evening, and I would like to introduce Dr. Tony Otway. She is a board certified obstetrician gynecologist residing currently in New Jersey. She has an undergraduate degree in biology and completed her studies at Florida Atlantic University with a residency at the University of Miami and also Staten Island University. She also went into private practice in Staten Island. She is currently a medical director um, for Horizon Blue Cross and Blue Shield of New Jersey. She has a keen interest in the health and wellness of women and children throughout New Jersey. So I would like to introduce to you our presenter for this evening, Dr. Tony Otway.
Hi, all. Thank you very much for inviting me into this. I'm excited about giving my little talk on, hopefully, it's a subject that is not too close to too many people's heart, but to give some insight into that stage of life that we spend almost 40% of our lifespan in. I was a general OBGYN for 16 years. I had a private practice and I pivoted into working for Horizon after 16 years because it was burnout and I needed to spend some time with my child and have a better work-life balance. So within that time and all during my private practice, I've always worked at institutions that have needed or helped women, especially women with either underinsured or no insurance, to obtain medical care. So you might be wondering, what is the link between, I know that the series that you guys have been talking about is more about maternal morbidity or mortality, and what is the link between this and maternal morbidity and mortality? So it's a huge link between the two. Your reproductive health history and your menopause experience and long-term health care are very, very linked together. Disorders that arise in pregnancy, such as hypertensive disorders, such as preeclampsia, increase risk of cardiovascular disease later in life. It can lead to earlier menopause, complications such as placental abruption, which is when the placenta separates from the uterus prematurely, preeclampsia, gestational diabetes. All of these can lead to earlier menopause. And with that, increased risk of osteoporosis and cognitive decline. So it's very important for you to be aware of this during any time, pregnancy or earlier in life, just to set yourself up for a better transition into the menopausal years. So perimenopause, basically, the talk I'm about to give is the who, what, when, and where, and the how to survive in menopause. I'm just going to give a brief overview because this is a really, really deep subject. Next slide. Next slide. Okay, so perimenopause, this happens to all who identify as women and who are born with ovaries. It's a natural, inevitable event. Over the years, I think with this Western society, Western culture, menopause has been looked at as something that is a medical condition, but in most uh, areas throughout the world, it is looked at as a natural progression or a transformation from the old self to a new menopausal version of yourself. And it's looked at as a rite of passage. Women have attained status within the community. And it's something that's not looked at as a medical condition or something to fear. And I think that is a more Western approach to looking at menopause. And I think one of the reasons why we might have such an issue with it is because we're going into it with this idea that it is frightening and it's something to be feared and it's something that we need to fight. Whereas most cultures, it's just a natural progression. It's not a loss of estrogen, it's a change in your hormones. And that's how most people look at it. It's a change in the hormones. It's a decrease in the hormones. And it's something that should possibly be embraced and not looked at as something that we need to fight against. So it was first described in 1821 as a debilitating disease. And in 1966, they described as a hormone deficiency disease. And this is all more Western thoughts. So at that time, they found that estrogen was one of the medications that could be used to help women go through menopause, all the symptoms that are that you encounter. And in the 1970s, they added progesterone to protect the uterus from endometrial cancer. But then there was a study in 1998 called the Women's Health Initiative study that wanted to know what the effect of HRT had on the most common causes of death and disability in postmenopausal women. But it was stopped very early in the trial because they found that there was an increased risk of women who had cardiovascular disease and breast cancer. Next slide. So this is just an indication of what's been going on in the past couple of years. There's been a huge increase in public interest in menopause, but not necessarily an increase in teaching medical directors, physicians in medical school in how to treat menopausal women. But more and more women are talking about it. More and more studies are starting to come up to be done. And you see it all over the news now. It's everybody's talking about it, but we still don't have, great treatment. We still don't have great studies. But it is something that is being discussed more. Next slide. So the reason we're finding that the original WHI study was flawed was because they enrolled women that were at least 10 years postmenopausal. And at that point, because they had lost or had decrease in estrogen, they were already setting themselves up with chronic disease. So they were actually treating women who already were having the kind of diseases and medical problems that estrogen helped to prevent while they were menstruating, or even in the early years, just when they started having menopause. So that was one reason. They've been enrolling women who already had chronic problems. And because of that, and because they stopped the study, a whole generation now has been lost to what we call inadequate care. So there's been a whole generation of women that have not been treated appropriately in those menopausal years. And it's also become an economic issue because at least a fifth of women want to retire early because they're finding it too difficult to work through this transition, because we don't have proper education about how to treat it or what to use. And 80% state it's still challenging to work through this transition. Next slide.
Dr. Otway, it's Tracy. I have a question just to bring this back home. So, what we're seeing is really a shift in the understanding of menopause right now. And I think we're in the throes of this process
Right.
because, as you stated in the previous slide, many of us came up with the thought that you do not take hormone therapy after a certain age because it puts you at a risk for cancer, for
Right.
heart disease.
Right.
And as you said, it's very important, and I want to reinforce this. The study was flawed because the participants were already 10 years postmenopausal.
Menopause,
So
okay.
they were at increased risk for those conditions already,
Right.
based on the fact that they were already past the menopausal. And I want the participants to understand that's why we're seeing such a shift, and to reinforce that generations of women went through this process and could have been helped with the symptoms, but based on this study, which was pretty recent compared to a lot of information that's out there when you look at scientific studies. So this is where we are right now. And then we'll talk about, that famous hormone estrogen. And as you said, it's not a loss, it's a decline. So I'll let you continue.
Right. So the other things that were flawed with the study too was the type of estrogen that they were given to women. They were given very high dose ones, and how it was given to them, because you could take estrogen a number of different ways, whether by mouth, whether by patch, whether by gel. So there was a number of things that were flawed with this study. But we didn't take the time to actually look at the results, and it's just been a scare for anybody to even, take up the baton and to run with it again to see if what we can really do with it. So this is just basically an overview of what your estrogen hormone levels are through the ages. You can see as you're 20, it peaks at 35 and then starts to go down and down, down as you get older. And it's this decrease in the hormone level that increases your menopausal symptoms and puts you into menopause. Next slide. So there's actually 3 phases of menopause. There's the perimenopause, the menopause, and the postmenopause. Next slide. So the perimenopause is a transition period, usually lasting about 3 to 5 years, averages 4, and it marks the beginning of menopause. This is when your estrogen levels start to decline. Usually average age is in your 40s. You start to have irregular cycles. You can start to experience all the other symptoms. You may have hot flashes, night sweats, difficulty sleeping, increased weight gain, brain fog, all those things that you hear about. This is the time that some of these things can start to happen. And everything about this phase actually varies from person to person. Next slide. So what menopause is actually when you officially reach menopause is when you've not had a menstrual period for a full year. It has to be a whole year before you can say you're truly in menopause. This is when your ovaries have stopped producing most of the estrogen and no longer releases any eggs. And please be aware that if you still get a period, you can still get pregnant. It's not unusual. Symptoms may still continue, but are likely to lessen over time. You are now at increased risk for certain conditions, and the average age of this is 51 to 52 years. Next slide. So the myth that menopause only happens when you're old, there's actually 4 different ways of becoming menopausal. It can occur naturally, again, between the ages of 51, 52, maybe a few years before, maybe a few years after. It can come early, which is usually around 45. It can be what they call premature, which occurs before 40. And that can be because of medication, treatment, say like if you have breast cancer and you have to have chemo, or you have what they call premature ovarian failure. And it also could be induced. So if you have to have a hysterectomy and they take your ovaries, so then you will absolutely go into menopause. And this could be from an illness or a loss of ovarian function. Next slide. So postmenopause, this occurs after you reach in menopause. Some of the symptoms, again, are expected to decrease or go away, but you still may have things like hot flashes. Some symptoms remain or get worse, such as vaginal dryness, and some of the increased health risks remain the same. Next slide. So what is perimenopause, which is this really what people are trying to understand and help treat. So this is really an erratic fluctuation in your estrogen. Again, it can occur starting from the ages of 40s to 50s, average is 51 of menopause. It's a natural process that causes physical and emotional symptoms. It does not always need treatment. It depends on the severity of the symptoms. And of the numerous symptoms you could have, None, some, or all, and everybody is different. There's not a singular event, but it's a complex transition. And there are over 30 documented symptoms. But the myth, menopause is the same for everyone. It's a myth. Everybody is different, and everybody will experience it differently. Next slide. So with menopause, this is a slide that basically shows you all the different ways, areas that you can have symptoms. There are over 400 estrogen receptors all over the body. So from your head, hair, skin, all the way down to your toes and everything in between, you can have effects of menopause. You know, hot flashes, anxiety, depression, joint pain, irregular periods, vaginal dryness, all of these things can happen. 400 estrogen receptors all over your body. So it's a huge effect on your system when you do start to see that decline in estrogen.
So,
Next.
Dr. Otway, looking at this slide, and I think it's very important and to call out to our participants. So many of the symptoms that you're seeing, estrogen is such a strong hormone, and it for women, it controls a lot of functions within our body. So when you're going to the physician and you're seeing all of these symptoms, we want, as part of our education, to keep these in mind. It may not just be one thing, that all of these things can be happening, because if you go back to the slide where it showed that the estrogen was declining, it's not stopping all of a sudden, it's actually declining. So all of these symptoms kind of tie in with each other. So it's like we need to pay attention to our bodies,
Right.
because what's going to happen is unique to us as the individual.
Right. Absolutely. Absolutely. Next slide. So some of the symptoms I've already mentioned, your periods, and your periods could do everything from getting shorter, getting longer. The time in between your periods could get shorter or longer. You can bleed heavier, you can bleed lighter. It's every single variation is a possibility. Again, hot flashes, night sweats, insomnia, anxiety, depression, changes in your sex drive, vaginal dryness, and brain fog. Next slide. So this is just a quick overview again of all the different things that can happen when you start to lose or have a decrease in your estrogen. Next slide. So some of the effects of the change, the most important ones are bone health, heart health, hot flashes, and the brain fog. I think these are the most frequent issues that people have when they start to go through these changes. Next slide. So with bone health, osteoporosis is what is called when you start to lose your bone. It's a skeletal disorder. It's characterized by compromised bone strength, leading to increased risk of fractures. So estrogen plays a crucial role in maintaining your bone density. The loss of estrogen leads to bone loss. It's a very silent disease. It happens over a number of years, and it's very hard to actually see you change in, some people may change their height, but it's something you don't really feel is happening. You can get increased fractures that can occur, especially in the spine and the hip. And bone in the spine can crumble and collapse, leading to pain, loss of height, and hunched posture. And this risk increases with age and being postmenopausal. Next slide. So, did we skip a slide? I'm sorry. Can we go back one? Right, okay. So it is preventable and it's treatable, but most women are not screened. So the risks of osteoporosis is your postmenopausal, your older age, small body, family history, diet, any medications, medical conditions, lifestyle. If you smoke, you drink a lot of alcohol, these can all increase your risk of osteoporosis. You should be screened at least by the age of 65 and older. But if you're postmenopausal under 65 with risk factors, you should also be screened. And any adults that have what they call fragility fractures, which is fractures just from if you just, you're standing up and you just happen to fall And if you end up with a fracture, you should also be screened for osteoporosis. And if you have maybe a disease that could be associated with increased risk, there are diseases that decrease your absorption of calcium, or immunosuppressive diseases. Maybe if you're using steroids, these can all lead to increased bone loss. If you have a loss of height of over 1.5 inches, if you have broken bones in your back, again, chronic steroid use, these are all risk factors for osteoporosis. And the test that we all need to get for this is a bone density scan. Next slide. So how do we prevent? Biggest thing is lifestyle. Try and avoid your tobacco use or excess alcohol. Make sure you're getting your daily calcium and your vitamin D, which helps to reduce your risk of hip fractures. Balance training. Biggest thing with osteoporosis is to try and strengthen your bones by exercising, doing weight-bearing exercises, strength training 2 to 3 times a week. If you try to do 30 minutes or more of moderate physical exercise for most days of the week, if not all, and making sure you have good vision, you go for your eye exams, because a lot of these times it could just be that you trip over a rug or you don't see something and you fall over. Make sure you get your eye exams also. Next slide. So some of the medical therapies we use hormone replacement therapy. We use medications called anti-reabsorptive medications, which help to decrease the bone loss, such as Fosamax, Evista, Prolia. Probably some of you may be on some of these things. And some of the other medications are Forteo. You can do it with pills. There's some injections. But you also need to be aware of some of the side effects, especially with Fosamax. There was a big study that showed that some people got a condition called osteonecrosis of the jaw with some of these medications. So also remember to always go for your dental exams if you are on any of these medications. And this your bone density screen needs to be monitored every 1 to 2 years. Next slide.
Dr. Otway, just a quick question. When you talked about the osteogenesis of the jaw, was that the
Process.
losing the bone loss in the jaw?
Bone loss in your jaw, yeah, in your
Okay.
jaw. Okay.
Thank you.
And by that, then it would affect your teeth, and it's a big.
So it all ties into dental
Sure.
health and everything, just making
Yeah.
sure that we get those checkups.
Right. So with the heart health, we're going to look at some risk factors for cardiovascular disease. So cardiovascular disease is more common in women than men, but presents later in life, only because we have that protective effect of the estrogen. It is a leading cause of death in women in the developed world. You got to, like I said before, women spend at least 40% of their lifetime in menopause. So we have more time for cardiovascular disease to develop. Prevention, sudden cardiac death is often the first manifestation of cardiovascular disease in women. We have also the worst outcomes when it comes to acute heart attacks. Next slide. A lot of that is because, we go to the emergency room, we say, we have chest pain, and, it was a point that a lot of physicians didn't believe we were having actual heart attacks. We weren't presenting the same way that men were presenting with heart attacks. So it's a culture, it's a bias that we find throughout the medical care that they don't always listen to us. They don't always understand that we present differently, but I think it's changing over time. So traditionally, the risk factors for cardiovascular disease is diabetes, smoking, obesity, being overweight, being inactive physically, if you have high blood pressure, if your cholesterol and your lipid levels are all abnormal. But some of the more recent risk factors we are finding out, which ties back to maternal health, is if you have preterm labor, if you have hypertensive disorders in pregnancy, gestational diabetes, if you have autoimmune diseases or breast cancer treatments, depression. All these things can lead to early menopause. You have to understand that pregnancy itself is a huge stress on the body. And then if you start adding in some of the medical problems that you have that are just related to pregnancy, it just accumulates the risks to later on in life to have some of these risk factors for cardiovascular disease. So it's always, you have to be mindful of when you are pregnant, you need to remember to make sure you're taking care of yourself, your visits, taking your medications, and just trying to stay active throughout the pregnancy, keeping your weight down, all those things that you need to have an optimum pregnancy can also help to decrease your risk and the issues that you may have later on in life in menopause. Next slide. So menopause therapy should not be used for menopause, should only be used for menopausal symptoms, not to reduce your cardiovascular risk. But hormone replacement therapy does help with this. It does have an effect on your body mass index. Your weight doesn't usually change, or you gain less weight, and you don't gain as much of a male pattern weight gain if you are on hormone replacement therapy. It helps to keep your blood pressure in check. It helps to keep your blood sugar in check, and it improves your cholesterol and your lipid profiles. So the reasons why we don't one of the reasons why the study was bad was because they were putting these women in there that were already seeing these chronic diseases. So there's a thing called a timing hypothesis, which basically is estrogen is more helpful the earlier you start to use it. When your estrogen receptors are still very active and you've had less chance of having detrimental effects on your blood vessels. So what we found is that if you're more than like 10 years out of menopause, your estrogen receptors are very, very, very low. So if you start to give people hormone replacement therapy, the effects are not going to be the same because you just don't have the receptors there anymore. So the whole timing hypothesis is something that is being investigated, and they're looking at trying to start women on hormone replacement therapy sooner rather than later, at least within the first 2 to 4 years of being being into menopause. But once you are 10 years out or over 60, 65, there's really not much benefit to actually starting hormone replacement therapy at that point. Next slide.
So it's really, when we're talking about hormone therapy, again, it's having that conversation with your GYN and your general practitioner, and even if you have a cardiologist,
Right.
having those conversations, because that's that coordination of care that we want to have so that everyone is on the same page, and also advocating for yourself as the woman to say, I want this.
Absolutely.
Because it will help me with my symptoms. As you said, with the male pattern weight gain, which is, you didn't have a belly before and all of a sudden you have a belly. So all of those things. So it's about talking to all your healthcare practitioners and arming yourself with the knowledge when you go in and saying that this is something that I want, and collaborate.
Right. So heart health is really all about prevention. It's lifestyle modifications such as diet and exercise, medications to help improve your cholesterol and lipid levels, making sure your blood pressure is under control and your glucose is under control. And prevention is very important. Sudden cardiac death, again, is often the first manifestation of cardiovascular disease in women. Next slide. So this is a huge one. I know everybody's probably, some people maybe even have their fans out right now. I don't know. Next slide. So hot flashes, as many as 73% of women are not treated. Estrogen helps to maintain your body temperature by controlling the thermoregulation center in the brain. All hot flash outcomes improve with hormone therapy. And hormone therapy is very effective for moderate to severe disease symptoms. Both the North American Society and ACOG and the Endocrine Society all support the use of systemic therapy in symptomatic relief of menopausal women without any contraindications. Next slide. So who are the good candidates for these? These are people who are symptomatic, less than 60 years of age or less than 10 years postmenopausal. They're experiencing bothersome hot flashes, night sweats, otherwise known as vasomotor symptoms, and they have no contraindications. And these contraindications are unexplained vaginal bleeding, if they have estrogen-sensitive breast and cancer or cancer of the uterus, if they have history of blood clots, if they have severe coronary artery disease, if they have high triglyceride levels or chronic liver disease. These are not good candidates for people to be taking hormone replacement therapy. So the FDA has approved this therapy for, they have approved estrogen. If you still have a uterus, you need to make sure you have estrogen and progesterone. And you can also use oral, vaginal, topical options, patches that go on the skin. And some of the non-hormonal ones are things like SSRIs, which are antidepressants such as Prozac. There's a new one out called Veozah, which actually works on the brain, which seems to be helping also. Next slide. So some of the non-hormone therapy is the SSRIs, the SNRIs, which are all these are all anti-depressive medications, things like Prozac, Celexa, Zoloft, things like Cymbalta, Effexor. There's a gabapentin is a medication that they use for seizures. Oxybutynin is something that you can also use for if you have urinary symptoms also. And some of the other non-hormonal things are soy foods, extracts, over-the-counter supplements and herbal therapies. Some people even swear by cannabinoids such as marijuana. And then some of the other things are also trying to decrease your stress level, things like acupuncture, yoga, relaxation exercises, and cognitive behavior can also help with some of these symptoms. Next slide. So those women that have a history of breast cancer who don't want to take any kind of estrogen therapy, non-pharmacological ones or things that are not estrogen are, again, cognitive behavior, acupuncture, hypnosis, yoga, relaxation. But they can also take the antidepressants, such as what I was mentioning before, the Prozacs, the Cymbaltas, the gabapentin. But there is research now into using estrogen preparations that are not taken by mouth, that are given vaginally or through the skin, low dose ones. And there are some studies that are encouraging in that women with breast cancer can use these different types, different forms of estrogen to help them with their symptoms of menopause.
Dr. Otway, a quick question. For the pharmacological treatment, the use of antidepressants, how does that factor in, or what's the connection between the hormonal treatments?
Well, that it's because it works on the brain,
Got
and
it.
it the thermoregulation, especially for hot flashes, is really what's going on in the brain. So these are all things that help to regulate your hormones in the brain, and that's how they work.
Yep. Thank you.
So moving to the brain. Okay, next slide. So there's this thing called brain fog, mental health. No, we are not going crazy, which that's what a lot of men try to tell us. You're going crazy when you're going through the menopausal years. It is not all in our head. Sorry, it is actually in our head. Things like the memory lapses, the clouded thoughts, the mental health changes are from those changes in our brain due to the changes in estrogen. So with mental health, you may find you have new incidences of mental health, depression, anxiety. If you had history of mental health issues before, it may come back. It may be worse. Things like anxiety or depressive illnesses. And if you have anxiety and depression and you think it's controlled, going through menopause may actually make it more severe. and it can actually peak during the perimenopausal period. So the risk of having these issues, mental health, brain fog, is previous history of mental health disorders. If you have vasomotor symptoms, the hot flash, the sleep disturbances, which will make anybody go crazy if you're not getting enough sleep. And postpartum depression is a huge one. So again, this ties back to that whole maternal morbidity, is making sure that postpartum depression is recognized and treated, and just understanding that you are at an increased risk of having issues when you go through the menopausal years. Next slide. So we need to really up our identification of women that may need these either hormone replacement therapy or some kind of therapy. So we need to increase our screening, and being able to identify those women that need this kind of help. So your OBGYN should be playing a very important role in detecting and coordinating care if you need it. It's usually the first point of contact, because usually OBGYNs are usually the first point of contact into the medical system for most women. And they need to increase their screening at times, more times of vulnerability. They should be routinely screening you every year. They should be asking you how you're feeling, how are your mood changes, how are you sleeping well. And the aim is to try for early detection of any changes that people might be happening, and so we can help to possibly prevent and treat some of these conditions. Next slide. So the effects that a decrease in estrogen has on is there's a decrease in the blood flow to the brain. There's a decrease in how the brain uses energy, and the actual structure of the brain is also affected. There's areas that the brain shrinks. There's changes in the composition, and all of these are things that occur once you have that decrease in estrogen. So things are disrupted. Your mood is disrupted. Your memory is disrupted, cognitive function is disrupted. And these changes are actually seen in scans, because we're seeing these same changes in women or people that have dementia and Alzheimer's. We are actually, I think, 2 times more chance of getting Alzheimer's than men, but it usually affects us at a later age. And one of the biggest things is the brain scans of physically active women have fewer Alzheimer biomarkers compared to women who are not active. So that whole looking after yourself and making sure you're exercising and keeping yourself active does have an effect on the brain changes. Next slide. Again, lifestyle change, what to do, diet, exercise, hormone therapy, behavioral therapy, things like mind-body practices, CBT, movement, hypnosis, meditation, breathing exercises. These are all things that can help. Next slide. So here we get, again, was the timing hypothesis. Estrogen is helpful early when estrogen receptors are still active. Vessel disease is not developed, and it's helped better in younger women closer to the onset of menopause. We're seeing that we're coming full circle since the WHI study. And last year in the UK, they were seeing a shortage of hormone medications because more and more women are seeing the benefit of it and requesting it. And it should be part of a general prevention strategy at the onset of menopause. And it's actually a major opportunity to prevent chronic diseases that start 10 years after the menopause. This is when we start to see it. But if we start it early enough, we start to see that these chronic diseases start much later on in life. Next slide. So this is just a slide. This change looks different on everyone. It happens differently in every single person, and there's no set method or the way it presents itself. It's all different for every single person. Next slide. So some of the things that we have to take into account, as Tracy said, you have to be an advocate for yourself. There's racial differences in how women experience this time. There are cultural differences, as I just said before. A lot of different cultures actually see this as a time as a transformation from your old self to a new menopausal version. In Japan, they don't even have a word for hot flashes. Most cultures actually embrace this time. It's a freeing time for most women because you no longer have, your monthly periods. And they are seen differently within the community. They're seen as wise people. So I think it's a very Western outlook that menopause is something that we should be scared of. I don't think we should. We should be embracing it. And I think that's part of the problem is how we're actually looking at it. There are differences in how women are educated about menopause within cultures, racially. There's barriers to overcome, and there's a bias within the healthcare system on how medical doctors look at different women, and you go in there and the same two women might say, well, I'm having an issue with brain fog, and one may have a $1 million workup and one may not, based on biases, whether it's racial, social, economic status, um, all different areas. And we also need to do a better job at educating our doctors that are in medical school. When I was going through medical school, I don't think we had many classes at all on this issue. It was really taught while we were in our clinicals, when I was in residency, but actually to have a course during medical school to really look into this, it was not done when I was going through medical school. Next slide. So what to do again, educate yourselves, become more empowered. You should demand and deserve better treatment and be more aware. Just you talk a lot amongst yourselves to your practitioners and just be an advocate for yourself within the healthcare field. There's a need for more research, especially over a range of different types of women, ethnicity, socioeconomic status, to try and understand exactly what is going on in this transition time. Next slide. So this for me is huge. If you take nothing else from this talk, you get your Centrum Women's one a day. It gives you all kinds of vitamins for every part of your body that you need to try and help. I have to use a chewable because I can't take those big pills. They're massive. But if every single day, women's one a day, this is what you need to be doing. This is the least you should be doing, is taking your women's one a day. And with that is my talk. We have a little slide of some resources you can go to. American College of Obstetrics and Gynecology, North American Society of Menopause, and there's a I can't remember her name, Dr. Missoni.
I think we have it. Yeah, I think we have
Yeah.
it on the slide. Yes.
Dr. Lisa Mosconi, right? She's a neuro scientist who is doing great work on menopause, the menopause brain, and how menopause affects our brain in terms of Alzheimer's, dementia, the whole thing with brain fog. So you can follow her on Instagram. She does a lot of TED Talks. She has a book. She's really a great source, and she's doing a lot of great work in terms of menopause in the brain. And that's my talk.
Well, thank you, Dr. Otway. I think you gave us a wealth of information and you gave us a lot of things to think about. And as women, I think we need to look at ourselves individually and take this information and arm ourselves when we go to our physicians and just be that true advocate. And also look at the type of physician that you're going to, because if that physician is not listening to you, it may be time to change. Maybe the physician that you had when you were a certain age may not be the physician that you need to as you transition during this period, whether it's perimenopausal symptoms or menopausal symptoms that you're going through.
Right.
So I know that there are some questions in the chat, um, but I think there's one so far, and I will go ahead. It says there's so many symptoms. How do you know when it's perimenopause or something else to be concerned about?
The only thing you can do is you have to go to see your provider. You have to explain to them exactly what's going on. I always encourage people to write things down. Um, Dates, times, what were you doing when your symptoms were occurring? Um, Something, like your hot flashes, your night sweats, what was going on? Were you exercising? Were you feeling heart palpitations? What is if it's a bleeding that's happening? What's going on with your bleeding? Always keep a diary of these things so you can go to them and you say to them, this is what I'm experiencing. And don't just have them tell you, or maybe you're going through the changes. Get them to show you that you're going through the changes and that it's not something else. There's many different disease processes that can mimic some of these symptoms. So they have to be ruled out depending on what the symptoms are that you're having. But a good idea is if you're feeling that things are changing within you, keep a diary, jot it down. And when you go to your provider, you tell them this and this and this is what's been happening over this period of time.
Right. There's another comment also, and this goes back to our oral health. Menopause also impacts the oral cavity and can cause dry mouth that can result in increased cavities, gum, and sensitivity. So it's the whole health continuum. And thank you for the comment from the chat. So you should pay attention to your oral health just as much because it's all connected. Your
Okay.
oral health, your cardiovascular health, all of that plays a part. So if you're experiencing these symptoms, again, we have to be comfortable with talking about what's going on with our bodies. And if you don't have the right practitioner, I would encourage people to seek out those practitioners.
Absolutely. Absolutely.
Another question that comes up common: do I need a pap test and a mammogram if I'm in menopause or after menopause? There's been a lot of confusion about when I get a PAP, and the PAP is, the internal examination and culture taking during the GYN exam.
Right.
So, do I still need that?
You still need to go for your exam because you can get cancer, you can get vaginal cancer, you can get vulva cancer, even when you're postmenopausal. So you still need an actual exam for your OBGYN to actually take a look at the skin, look inside and make sure things look okay. You don't necessarily need a pap smear all the time. Usually if you're over 35 and your pap smears have basically been normal for the years and you've never had an issue with HPV, you can start to spread out your pap smears. So it's really what your history has been with your pap smears. The mammogram, every year still go for your mammograms. I don't care how old you are. My mother had breast cancer when she was 85.
Mhm.
So, and all her sisters kept telling her, why are you still going? Why are you still going? Because she says, my daughter told me I have to keep going. So I keep going. And she had breast cancer. So not so much for the pap smear, but again, you still have to go for your exam. They still need to examine you and make sure that everything looks, okay. And based on your pap smear history will depend on how often you still get a pap.
So it really
Mammogram,
is,
definitely.
and when it comes to pap smears, it's about your reproductive history and whether you're sexually active or however.
Mhm.
Those are conversations that you need to have openly with
Right.
your practitioner, and you can again coordinate that care.
Hmm.
Another question is, if I start hormone therapy prior to when my symptoms are just starting, the estrogen receptors are still there, how long will I have to be on it?
And we usually start off at 5 years. And then a lot of people find that when they start to come off, they start to get all the symptoms back. But it could just be a rebound effect. But it could still be that you're still having issues and you keep going on it. The studies are still not, conclusive of when to actually stop. But the best time to actually take it is within those first couple of years. That's the most time benefit you're going to get from taking hormone replacement therapy.
Mhm.
Um, so initially it's been about 5 years and then you talk to your doctor about it and you see and again, it depends if you have any risk factors for anything. If you have those risk factors for osteoporosis, you could stay on it. I mean, it's either that or you take something like Fosamax. So you're going to have to take something to maintain that bone. So it all depends on where your risk factors are, how you're feeling. So we still don't have a concrete answer to that one. Because again, you know, with that study, it really did frighten everybody off. And you know, women's health is always on the, you know, the bottom of the ladder. And, you know, it hasn't, you know, we don't have as many people doing studies now as we should. I wish we had more studies that were in parallel to the interest that women are having in treating this, you know, menopause. But the studies are still lacking. So, you know, we still don't have really good answers for that yet.
Okay. Another question that has come up, synthetic hormones. Going to different physicians that do compounds and they test your hormone levels and they come up with synthetic hormones to treat your symptoms. Can you talk about that a little bit?
Sure. So the compounding hormones, and you got to understand they're not FDA approved. Um, and you really shouldn't be testing your hormone levels. It really should be about your symptoms and your risk factors. Um, we're going to give you the lowest dose hormones that you need. So testing them is really not going to help. Some people have flocked to the compounding ones because they feel it's more natural, but it is not FDA approved. So really make sure you know who you're going to, what kind of experience they have with these compounds, and each you know compounding place is different. They're not really regulated, so you have to be really careful where you're getting these things from.
Okay. I have one more question. And I think we touched upon this because we're getting near our time. But perimenopause can affect not only the body, but the emotions as well. Um, and these people who have perimenopause seem to be at more risk for depression. So as they're experiencing perimenopausal symptoms, because they're in that age, 35, 45, so there's a lot going on, career, they may have families and other things. What suggestions would you have for individuals who may are in that age range that may be beginning to experience perimenopausal symptoms, but also having signs and symptoms of a mild depression? Because as African American women, we tend to have high functioning depression. So we're still going and going and going and going. And we're really having those symptoms.
Right. As I said before, I think the biggest thing is really prevention. Things like lifestyle changes, exercise. I can't emphasize exercise, you know, more than what I am. Um, you know, you're decreasing your alcohol intake, if you're smoking, eating right, eating the rainbow, don't, you know, making sure you're keeping your weight down. But exercise is a huge one. It's a stress relief, and just seeking out those things that can decrease your stress. And if you're feeling that you are having issues, you need to go see your provider. There are tests that you can take to score you and see where you are on, you know, depression or anxiety. But don't be afraid of it. And I think that's a huge thing within our community is, you know, not wanting to go to see psychiatrists or therapists or go on any medication. There's a big stigma to it still. My husband feels that every single person should be, you know, should have a therapist at some time, all the time, you know. And we even encouraged my daughter. She was, you know, in high school, and he made her go see someone, just to go see someone, because he feels that everybody should have someone to talk to. And now she even comes to us and says, I think I just think I want to speak to such and such. I got some issues. I just want to just sound them out. You know, she doesn't want us to talk to us about it, but that's a huge thing. We have a big stigma in our community about seeking help, and we need to get over that. We really do. But
So it sounds like
lifestyle change,
normalizing
right?
normalizing the ability to ask for help.
Right.
So one other question was, is the real opportunity with hormone replacement therapy to prevent chronic illness, or is it going to delay the development of chronic illness?
Well, it's going to help prevent chronic illness. Okay, if you're taking it, you got to understand that we, like I said, we are in menopause at least for 30 to 40% of our life, and the longer we can put off those chronic illnesses, the better it is for us. Um, but along with that, it has to be a lifestyle change. It can't just be that you're taking hormone replacement therapy. It's to help with all the other things that you need to do, the exercise, the diet, and making sure you're going for testing, to make sure you're taking your medication if you need to take your medication, and going for your regular checkups. So it's really trying to prevent those chronic illnesses that occur, at least 10 years out of menopause. So if you can prevent that, till you're hitting maybe 75, 80, it's still going to take a long time for those chronic illnesses to actually build up to a point where it's going to be a problem. So the longer you can put it off, the better it is.
Okay, great. So I'm going to do the last two questions and put them together. So the signs and symptoms of menopause, and we're talking about our sexual health, and we have partners. So the question is two-pronged. What resources are available to our partners to explain the signs and symptoms of menopause? And also, how can we explain the physical symptoms that happens to our vaginal area as it relates to vaginal dryness in menopause? What can we do and have that conversation with our partners? Because as the vaginal dryness happens, sexual intercourse becomes uncomfortable.
Right, right.
So what can we do to help our partners with that and understand?
I think the biggest thing is really to educate yourself about what's happening with your body. So, because if you can't explain, if you don't know what's going on with your body, how can you explain it to somebody else what's going on with your body, and encourage them to help you, guide you, or help you through this transition period. Um, I think it's really about education. You need to be comfortable with what's going on. I mean, if you're with someone 20, 30 years, you should be able to talk to them and say, this is what's happening to me at this stage. Um, I need to explore things that we can use together that can make this a more comfortable experience for both me and you. But I think it's really about educating yourself and understanding yourself and not feeling embarrassed about it, being open with it. um, like I say, I use my daughter again. My daughter knew every single part of her body with the real names from when she was 4 or 5 years old. She could name everything. I just was straight up with her. And it's the same with my husband. Straight up with him. You just got to be, educate yourself, understand what's going on, and sit down just like you would sit down with your children with the books and the diagrams. You sit down with your husband, the books, the diagrams, and tell him exactly what's going on with your body.
Okay. I do know that, celebrities have some additional, resources. We have Oprah who's on the menopause bandwagon right now. So
Right.
I think what we'll do is maybe, we'll get some resources and maybe share some information because I do think that is an important topic again within our community because it's been like a taboo
Right.
topic to talk about menopause and what's going on with everyone. Well, I don't see any more questions in the chat. And I want to say to everyone, thank you for your questions. Thank you for your attention. I want to say, Dr. Otway, I work with you all the time. So it's been a pleasure for you to come on and to do this with us. And at that, I will turn it back over to Linda, who will have it
Yes.
for our president, Dr.
Thank you
Morel.
so much. Dr. Otway, you provided some valuable information. The responses on Facebook, one person said that they're reading that book that you gave as a resource right now. So we're getting on board with what we need to do for our bodies and for ourselves. I just want to let everyone know I just put in the chat an evaluation form. If you would kindly complete that so that we can continue to bring to you the kind of information that is needed for women in our community. And with that, I would ask our president, Dr. Mirella Holmes, if she would come on and say a few words. Is Morella still here? Okay, she may
Hello,
not
I'm still
be.
here. I'm still
Oh,
here.
okay.
I'm still here. I'm sorry.
Great. You're on. I don't know if you're on mute.
I'm here. Okay, I'm sorry. I'm sorry. Okay. All right. Whew. Thank you so much. Thank you so much. As you can tell, I was taking notes and trying to get all this information down and making sure that when I go to my doctor, I have the right terminology based that, some of the information you shared. But we're so thankful once again on behalf of the Trinity Alumni chapter of Delta Sigma Theta Sorority Incorporated, Dr. Otway, we're just so fortunate to have someone who looks like us to really walk us through some of the things. Is I know I come from a generation where my mom didn't necessarily share this information with us. In fact, it was menopause, perimenopause, postmenopause was a big secret. So thank you for coming on, sharing your wisdom, sharing your years of experience. It is so impactful to have someone who looks like us talk and have this very courageous conversation about something so many of us have been told not to talk about and just to silently suffer through, and to be armed with information. So when we do go to our doctors, we have information. We can talk knowledgeably and intelligently about what it is that we're experiencing, so that our health needs can be taken seriously. So thank you so much for coming on. Thank you to the Physical Health and Wellness Committee for thinking about this topic, because it is a topic that impacts so many African American women, and we do not have the information to arm ourselves. So kudos to you for having the foresight to put this webinar on. And with that, I will just defer now back to the chair, Linda Wyatt Simpson.
Thank you so much. This concludes our session. Um, is there anyone that has a pressing question to Dr. Otway from the audience? You can just come off of mute. We'll give you 2 minutes if you have something. I just want to make sure everyone has their questions answered. Okay, if there are none, thank you so much for joining us. Oh, do we have one?
Oh, okay.
Oh, okay.
I'm sorry. I was trying to find my unmute button.
Okay.
But I thought it was very interesting. I'm sorry. I'm Lucretia Davis, Trent Alumni Chapter. I thought it was very interesting to actually see the words that said it could be perimenopause or it could be something else.
Right.
And Soror Janelle asked, how do you know if it's menopause or if it's something else? Because I was going through a health crisis and I had night sweats.
Mm-hmm.
And I was like, I'm going through menopause. Like, I'm too young for this.
Mm-hmm.
And I mean, my hair would be soaked, my neck, I would have to change my clothes, my bed would be wet. I would have to lay a towel on my bed.
Right.
And my doctors were telling me it was night sweats. Come to find out, I have autoimmune conditions
Right.
that my body was going through. My cycle stopped. And I'm like, I don't even have a cycle. How is this going on?
Right.
I had no cycle. I had fibroids. I had a hysterectomy, laparoscopic when they should have cut me. It was just like a whole nightmare for years.
Right. Right.
And I felt like a 14-year-old, like I just did not know what was going on. So it was good to see those words as far as, is it menopause or is it really something else? And with me, it turned out to be like sarcoidosis and like a malfunctioning liver, malfunctioning organs,
Right.
and
Right.
fibromyalgia. Like, oh, I'm always tired. My joints, I was bruising easily. So it wasn't necessarily menopause.
Right. And yeah, and that's the thing, if you're not satisfied with the answer, you find someone else who can give you that answer.
And
You,
that's what I had to do.
you need to make sure that they tell you that it's nothing else but this. This is all it could possibly be, because
Yeah.
we've tested everything else. But don't be that go-to thing right off the bat without, investigating other things that it could possibly be. It could be a multitude of different things.
Yeah. So thank you so much for this like forum tonight. Thank you very much.
Pleasure.
A lot of information.
All right. Thank you for inviting me. Thank you.
And excuse me, I'm going to stop the live streaming because this is being live streamed on Facebook. So I'm going to stop it right now. Okay, Linda?
Thank you very much.
But you can continue. I'm just gonna stop